Hello, I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia. First, I want to welcome you back to this video interaction, and I want to highlight some very interesting new findings as are published in the American Society of Gastrointestinal Endoscopy recommendations that just were published in May as it relates to antibiotic prophylaxis for prevention of infection. Now, if I can back up for a second and set the stage, in October, if you're not familiar with this, you should be, the American Heart Association revamped their guidelines for prevention of endocarditis and justifying or not justifying the use of antibiotics. In fact, what they did after 50 years of recommending antibiotics for GI procedures for patients defined at risk for endocarditis, they revamped and said, the evidence doesn't support this any longer, and there are no recommendations for antibiotic use in prevention or the intent to prevent endocarditis in patients undergoing GI procedures. Now, the current issue of the ASGE guidelines as it relates to endoscopic procedures takes it a step further, and it looks at other indications, and there are several things that I just want to reiterate and then highlight for you and show you the differences. First, the endocarditis recommendations stand. It just doesn't make any sense. The bacteremic risk for an endoscopic procedure is incredibly low. In fact, over 20 million cases of endoscopy or endoscopic services are done yearly. There are only 15 cases in the literature that have any temporal association of development of endocarditis with an endoscopic procedure. So everybody has said, this doesn't make sense anymore. We can't justify this. And in fact, the complications of the use of antibiotics for all the antibiotic resistant strains we've seen, vancomycin resistant enterococcus, the number of antibiotics as it relates to use routinely for GI procedures, it just doesn't justify this anymore. So AHA and ASG now agree, no question, for endocarditis prevention there is no justification for antibiotics. Now, ASG guidelines take it a couple steps further. For joint prophylaxis, there is no guidance that supports the routine use for these antibiotics in joint prevention in patients with prosthetic joints. In patients that have prosthetic endografts, vascular grafts, again, no recommendation. If they have a endoscopic procedure that has biliary obstruction and you don't think you're going to clear the biliary obstruction, for example, if you had a hilar stricture or a patient with sclerosing cholangitis, that might make sense and that's recommended, but otherwise not even for biliary obstruction. If you're anticipating a fine needle aspirate for endoscopic ultrasound in a cystic lesion, it's recommended, not for a solid lesion routinely. To recommend this is no longer the case. If you have a PEG, a patient undergoing gastrostomy, it's still currently recommended. And if you have a cirrhotic patient that comes in bleeding because their bacteremic risk is quite high, in fact they may have some trace ascites, it's always recommended for a patient with ascites and GI bleeding and it's a cirrhotic to get antibiotics. So let's take a step back and say, what do we do for our patients? Well, it takes a lot of discussion, doesn't it? It's going to take a lot of re-edification. Your understanding of these guidelines is critical, and then your justification to the patient, because there's a lot of history here that tracks to that patient saying, I know I always get antibiotics for these procedures. Take a step back and take a look at what we do and say, do we have the evidence to support it? The answer is no, we don't have the evidence, and we may be actually causing problems. So come back to an Osler phrase of first do no harm. Consider your antibiotic use wisely, and take a step back and be familiar with these guidelines, because I think it's really eye-opening. Hopefully we'll have some dialogue that goes with this, and I'll invite you to dialogue with your peers and colleagues and connect with them in the interaction box below. I look forward to discussing this further interaction with you and look forward to also future events. Dr. David Johnson, thanks for listening.